Good evening, everyone. So this welcome everyone to our monthly case presentation meeting. This is number 27, and it's good to know that we've crossed 2 years right now. A warm Today's presentation will be done by Dr. Neerja, who's a third-year resident in MVR Cancer Center, Calicut. So the other news, what I heard is also it's her birthday today. So hopefully our examiners can, yes, probably keep that in mind as well. So anyway, happy birthday to you. And it gives me great pleasure to welcome our examiners today. So we have Professor Dr. Hari Menon, sir, who was my guide as well back in TMH, and then sir was in Sidecare, and currently he's professor in St. John's. And also we have Dr. Jayachandra, who also we had done the entrance, the running around through the entrance rigmarole back in the day. And now he's a professor in Adyar and handles hematology mostly. So we have two experts in hematology. So over to you, sirs.
Oh, and happy birthday, Dr. Neerja. Yeah. So can we start? Hello, Dr. Jayarachandran. Yeah.
Hello, sir. How are you? I'm fine.
Good. Thank you.
Yeah,
Thank you.
and
Thank you.
birthday wishes for Neeraj as well.
Good evening, sir. Thank you for the wishes. May I start the presentation?
Yeah, please.
So my patient is a 52-year-old male patient residing in Calicut. He's a teacher by occupation. He came with complaints of left-sided abdominal pain of 3 months duration and easy fatigability of 3 months duration. History of presenting illness. Patient developed left-sided abdominal pain about 3 months back. It was insidious in onset, dull aching, dragging type of pain. It was non-radiating, continuously present, not associated with any exacerbating or relieving factors. He also noticed easy fatigability about 3 months back, which has gradually increased over time. He also gives a positive history of early satiety. There is no history of any unintentional weight loss, no history of loss of appetite, no history of fever, night sweats, no history of yellowish discoloration of urinous urine, no history of any swelling anywhere in the body, no history of nausea, vomiting, black colored stools. Past history, there is no history of similar complaints in the past, no history of any comorbidities, he is not taking any medications at present, no history of any surgery, or no history of any repeated blood transfusion. Coming to the personal history, it's not a smoker or alcoholic, he has a mixed diet, bowel and bladder habits are normal. So, summarizing my history, my patient is a 52-year-old male patient who presented with complaint of left-sided abdominal pain of 3 months duration and easy fatigability of 3 months duration. Moving to the examination, he is having a ECG performance status of 1. He is well built, moderately nourished. He had pallor. There was no palpable lymphadenopathy or no other features in general examination. His vitals were stable. Coming to the examination of abdomen, on inspection, there was no relevant finding. But on palpation, spleen was palpable 10 centimeter below the left costal margin, which was extending downwards and medially, almost approaching midline, which was firm in consistency with a smooth surface. It was moving with respiration, and all the borders were both felt except the superior border. There was no hepatomegaly or no other palpable mass, no pulsation felt. On percussion, there was a dull knot in the left hypochondrium. There was no shifting dullness, no splenic rub on auscultation. Other system examination was within normal limit. A summary of my history and examination is a 52-year-old male patient with no comorbidities having complained of left-sided abdominal pain and easy fatigability of 3 months duration. On examination, found to have pallor and massive splenomegaly.
So, how do you approach this case? So what would be your differentials this patient?
So since he is having a massive splenomegaly associated with pallor, my differential diagnosis would be 1, chronic myeloproliferative disorder. Second one is chronic lymphoproliferative disorder. Most probably, I will be thinking in terms of this only. Sometimes benign causes can be there, but I couldn't find any other associated symptoms or associated findings, clinical findings. which correlate with other benign etiologies.
Okay. So, when you're confronted with something like this, okay, currently when you are in an oncology setting, you would start thinking of some sort of either a chronic lymphoproliferative disorder or in this case, a myeloproliferative disorder. Are there any pointers in the history that might skew towards the diagnosis of, I mean, to consideration for a myeloproliferative disorder? What are the many more, if, I mean, of course, this patient did not have, but what would have been some pointers to being a myeloproliferative disorder?
The chronicity of nature of symptom.
You say he was only symptomatic for 3 months. Yeah. So it's about 3 months he's been symptomatic. Okay.
So, what are the points towards and against chronic myeloproliferative disorder and chronic lymphoproliferative disorder? What do you expect additionally in a chronic lymphoproliferative disorder? Usually, additionally.
So in a chronic, there is no associated lymphadenopathy. Marcian splenomegaly, along with the pallor, with no associated lymphadenopathy, I am thinking more towards a myeloproliferative disorder.
Where do you get more of skin problems, skin changes, and where do we get more problems related to constitutional symptoms?
Lymphoproliferative disorders.
Okay, but if you're thinking about an acute lymphoproliferative disorder, isn't it? But what if you are thinking that this patient is present with 3-month history of course, so he has a lot of constitutional symptoms, which myeloproliferative disorder generally presents with fatigue, anemia, and a lot of constitutional symptoms,
Usually chronic
especially these symptoms. Yeah.
CML usually presents with fatigue, Marcian splenomegaly,
Okay.
lack of constitutional symptoms.
Okay. So, all right. So has he
Let me
lost, if suppose he had complaint of a loss of a lot of weight over here, would that point to something which is a feature of CML? CML generally, you don't get too much of weight loss unless, of course, unless he is transformed into a more aggressive form, like an accelerated phase uh, or a blast crisis. So one of the things that you might want to consider, especially because he's got a massive splenomegaly, he's got anemia, and if he has constitutional symptoms, and he has, is usually the other forms of myeloproliferative disorders, especially like myelofibrosis or just a non, even one of those neutrophilic, or the ones where you have primary leukocytosis, which is negative for yeah, for what you call of a PH chromosome, or the BCR-ABL transcripts. So what about skin changes? Suppose the patient had skin changes and suppose the patient had petechiae and purpurae, would that skew your diagnosis to something else, or that can also be a possibility of chronic myeloproliferative disorder and CML?
Chronic myeloproliferative disorder, there can be abnormal platelet function, which can cause
So where do you
ECD.
encounter that more frequently? Platelet dysfunctions.
Hypothesis.
Pardon me? So, which is a common condition where you have platelets patients present with a lot of large ecchymotic patches. You might have bleeding manifestations.
Lymphoproliferative disorders.
So that's a very broad base. This thing is usually in chronic myeloid leukemia, isn't it? Yeah. You get chronic myeloid leukemia. If you were to closely look, there is a platelet dysfunction over there. If you look at it. Yeah. So we have had situations where patients present with large petechiae, spontaneous ecchymotic patches, and even patients presenting with retroperitoneal hematomas sometimes. And any other things, any other things that may potentially say to patients with CML present with symptoms of hyperleukocytosis? Yeah.
Yes, sir. With total count can range from 2000 to about 4.5 lakh. So in case of highly increased total count, it can present with features of occlusion, hyperviscosity, causing blurring of vision.
Hyperviscosity ever happen in hyperviscosity syndromes? Is it a feature of CML?
So, do you think it's hyperviscosity or hyperleukocytosis? You have to I think you were confusing with the hyperviscosity. Hyperviscosity doesn't happen. Doesn't happen with CMLs. Usually, hyperviscosity happens with diseases where a lot of paraprotein is secreted.
So generally, what are the features of hyperviscosity syndrome? So if you were to look at that, hyperviscosity syndromes, what would the patient manifest with? Or be alert to that, okay, this patient probably has a hyperviscosity syndrome.
Dyspnea, drowsiness, loss of coordination, confusion,
yes.
vision.
Right. And even sometimes visual disturbances, isn't it? Yeah. Yeah. Visual disturbances is also a feature because they tend to develop um, retinal hemorrhages sometimes. Yeah. And exudates in the retina. Okay, so I think we're just digressing over here. So let's go ahead. And yeah, the differential diagnosis could be a chronic myeloproliferative disorder, which we have to ascertain what it might be. Rare for a chronic lymphoproliferative disorder to manifest with such a large spleen. But can you think about any chronic lymphoproliferative disorder which can manifest with large spleens?
Yes, sir. It would be hairy cell leukemia can manifest like that. Splenic marginal.
Usually hairy cells are moderate splenomegaly. Here you're talking about a massive splenomegaly. And yes, okay, it's possible. But generally, all the chronic lymphoproliferative generally fall into the mild to moderate splenomegaly kind of a thing. But there are a few chronic lymphoproliferative disorders which can present with massive splenomegaly also. You're right, hairy cell leukemia may be, but rare. But they would have manifestations of several other constitutional symptoms and yeah.
Splenic marginal lymphoma.
Large spleens sometimes, and even diffuse large B-cell lymphomas involving the spleen alone can manifest with massive splenomegaly. So yeah, so go ahead. I mean, I think we should just, yeah.
How would you like to proceed further? What is your first investigation of choice in this patient?
First investigation of choice would be a complete hemogram with a peripheral smear, sir. We have done a CPC for this patient. It showed anemia, hypertension.
When you say anemia, okay, oh, that is the blood counts. Okay, so she has a hemoglobin of 11.6, which is all right. Yeah, and hyperleukocytosis. Okay. So, okay. So what does this picture indicate? I mean, it's a Coulter report. It's not a classical peripheral smear. Yeah. So what is the peripheral smear? I mean, we can go back to the main thing itself because they have described certain things over there.
So there will be a neutrophilic leukocytosis. Here the neutrophils are highly elevated with a shift to left. That is more of immature forms of neutrophils are seen like promyelocyte, myelocyte, metamyelocyte. And basophils can also be in basophilia.
Okay.
Basophilia and eosinophilia.
So which is the one clinching thing over here that you would consider as probably skewing towards your diagnosis of, okay, you have a shift to left, but the shift to left can be in several other conditions, which is a one single entity over here, which you will think is skewing your diagnosis or your choice of diagnosis to be a chronic myeloid leukemia?
Space and blast.
Pardon me?
Basophil and blast.
Okay. Among the two, which one would you want to choose as the thing? It's the basophils, isn't it? Basophils are sometimes the one type of cell which we really look at and which is quite typical, especially in CML and CML chronic phase. And that sometimes what we even look at to distinguish between any other forms of chronic myeloproliferative disorder, or even for that matter, uh, other causes for shift to left. But you don't get this kind of a picture with other. Suppose I say that this is not chronic myeloid leukemia, which is another test that which you used to do. Nobody does it these days. What is it? Something else that you would want to consider over here? One enzyme assay that you would like to look at over here, which might clinch the diagnosis against. Yes.
Sir, in leukemioid reaction, that can be a high count. For differentiating that from CML, we can do a lab score. A lab
Yeah.
score less than 30 in CML and more than 160 in.
It's almost zero, isn't it, in CML, sometimes lab score? Yeah. Okay. Yeah, so go ahead. Yeah, so that's fair enough. I mean, but nowadays we don't do the lab score. We straight away go in for the other tests that are required over here. So looking at the peripheral smear, the differential, you look at the differential, what would be your interpretation of this peripheral smear? Is this like a chronic phase, or is it an accelerated phase, and how would you define that?
So this showing a neutrophilic leukocyte is a shift left. Blast percentage is only 2%. So I will categorize it as probably a CML in chronic phase.
Okay. Okay. So what are the cells that you will consider for what are in the so-called scoring system, and also for determining whether it's an accelerated phase? What is the cutoffs?
WHO criteria for defining accelerated phase. Blast in peripheral blood or bone marrow 10 to 19% blast. Then basophils 20% or more in the peripheral blood. Then total count more than 10,000 unresponsive to therapy. Persistence or increasing splenomegaly, persistent or increasing thrombocytopenia less than 1 lakh, persistent or increasing thrombocytosis more than 10 lakh, then presence of additional chromosome abnormalities.
Does all additional chromosome abnormalities qualify to become an accelerated phase?
The major root abnormalities, trisomy 8, isochromosome 70, and double Philadelphia.
So, does this report, with this report, when you have a peripheral smear and hemogram, would you be able to diagnose CML, or do you require something else to confirm as a confirmation? Would you be able to diagnose CML, chronic myeloid leukemia, as per the classification? Would you be able to diagnose CML with this report only?
This gives a pointer, but for the definite diagnosis, we request to detection of the PCR ABL transcript.
Say what? Oh, okay. What type of testing do you want to do?
I will do a qualitative RT-PCR for the detection of PCR ABL transcript.
I would say that the test is negative. Would you call this as a CML, or would you like to order some more tests?
Yes, sir. We will go for a fish because sometimes a typical transcript may not be picked up by the RT-PCR.
Good. So you need to confirm if it's a negative PCR ABL qualitative PCR, then you need to confirm by fish to say it's not a CML. So if the fish is also negative, then what do you call this disease as?
Can be called a typical CML previously, but now it is called MDS MPN with treats.
Now it's called MPN NOS.
So when you want to, okay, suppose we are having suppose the patient is having I mean, the clinical picture, the peripheral smear picture is quite typical of a chronic myeloproliferative disorder, possibly CML. But when you do the cytogenetics, and sometimes the PCR, you tend to, sometimes rare occasions, you don't get the so what will be your concerns, and how will you still, you think that it is a CML? How will you go about it? What else will you do to look at reconfirming the diagnosis or trying to confirm the diagnosis or initial suspicion of CML? Did you get my question? Yeah.
NGS can help in detecting the non-avial
But
non.
even NGS is looking at the transcripts only, isn't it? Sometimes you don't get the transcripts right. So what are suppose you have a CML. Most of the CMLs do have a P210 transcript. Would you want to do a qualitative analysis of the transcripts at baseline? And what are the different types of transcripts that you see at baseline uh, for a standard CML? What are the different types? And does that have any prognostic significance?
So the main transcript seems BCR transcript, major transcript, minor transcript, and micro transcript. Major transcript is P210, which is at 210 kilodalton molecular weight, and it is the E13A2 and E14A2 type of transcript.
Okay.
This is the most common one. Then you have the P190 protein, which is E1A2 transcript. That is seen mainly in Philadelphia, in ALF, Philadelphia positive ALF, but can also be seen in about percentage cases to see.
Do they have any prognostic significance? And why do we want to do this thing at baseline?
So, when we are reassessing the response, the quantification requires we need to know which drop to use for the particular transcript measurement of the data.
Okay. Now, I did ask a question as to whether if it becomes negative, do we encounter some things called cryptic translocations in CML? And are you aware of this concept of cryptic translocations in CML, and how do you diagnose those cryptic translocations? Do you know about cryptic translocations in CML?
It's like SETBP1 mutation. No, I don't know.
Exactly. Yeah, so you can have cryptic translocations, and those cryptic translocations, and that's where you would get the opportunity to utilize fish as a primary line of investigations. You will pick up those cryptic translocations only by fish. So yeah, so what we have to say is that even if you have a strong suspicion of CML and you're finding that now currently our tendency is towards making a BCR-ABL or doing a BCR-ABL, identifying through BCR-ABL by a qualitative and a quantitative PCR. Sometimes you may find it negative, and then you string fair, you might identify the cryptic translocation only on a FISH analysis. And that has to be kept in mind. There are quite a few case reports of that. And you're right, sometimes in NGS you can find out some of those, but it's more easy to do it by a FISH analysis. So that's a situation where a FISH analysis becomes important, and especially when you don't have when you strongly feel that it is still a CML and you don't find the transcripts over there. Yeah, so go ahead. Yeah.
Since the patient was having a very high count, we did other routine blood investigations, biochemistry investigation to rule out that the patient was in TLS. After that, we went ahead with the
Why do you say TLS? How often do you encounter TLS in CML, and in what situations? To my mind, those things have been very anecdotal and, in fact, case reports. Yeah. So why do you specifically say tumor lysis in patients with CML?
Since total count was highly elevated for this patient.
But do you anticipate that you will get tumor lysis in these patients?
In blast crisis, and when the patient is an accelerated phase, then
in which entity, which type of blast crisis do you anticipate that the patient will go into tumor lysis?
blast crisis.
Pardon me?
Lymphoid blast crisis.
Lymphoid blast crisis. So anyway, that doesn't appear even remotely over here, isn't it? So yeah, the reason why I'm saying is that many times people make a lot of allowance for tumor lysis and they give a lot of medication for tumor lysis. It is rare to occur. Though I will confess that um, uh, we did, when we were using imatinib the first time, it was reported as a case report from when I was studying at Ames. It was reported as a case report when actually we did have a tumor lysis, but those are all case reports. It never happens actually in real life. Yeah, I mean, your comments, Doctor?
Absolutely. Very rarely we encounter tumor lysis with a straightforward CML. Most commonly, it would be a lymphoid blast crisis and very rarely myeloid blast crisis.
So,
We have seen some other symptoms of hyperleukocytis, but not never uh, uh, tumor lysis syndrome per se.
yeah. So we don't encounter usually, but yeah. So my thing is that you should probably not be. I mean, you have to give some negative history, but it should be relevant to your subject at hand. Of course, you need to be ready with the answer if somebody asks you as to why you didn't mention tumor lysis. But generally, probably in this situation, I would probably not consider that as a thing as that we would consider that as a problem, as a potential problem over here. Anyway, let's go ahead. Yes, yeah.
We went ahead with a bone marrow aspiration and biopsy for the patient.
Why would you want to do a bone marrow over here, and what are the merits of doing a bone marrow here? What are you looking for? Yeah, that you cannot identify on a peripheral smear.
The bone marrow will give me the exact percentage of blast, so I can determine the phase of the disease, whether he is in chronic phase or blast, accelerated phase or
But
blast.
is the definition of accelerated phase and blast crisis based on the bone marrow, or is it on the peripheral smear?
Based on both, sir, but clusters of blast can be seen, if present can be seen in the bone marrow, then degree of fibrosis can be assessed, which is
That is important. So the degree of fibrosis is important in terms of the thing. And what's the other reason why would you want to do a bone marrow here?
genetics for additional chromosomal abnormality, which will upstage it to accelerated phase.
Yes. So unless you know what is the baseline the cytogenetic profile, you'll never be able to demonstrate if there is a clonal evolution in these patients down the line, isn't it? Yeah. So, yeah. So currently, many people don't do bone marrows, but at this point, but yes, and from an academic perspective, it is always good to do a bone marrow aspiration biopsy, especially a biopsy at baseline diagnosis. But most people don't do it these days. Yeah, so let's go ahead. Yeah.
So for this patient, we did a qualitative RT-PCR. It detected E14A2 type of transcript.
You did a qualitative, okay? Yeah.
E14A2 type of transcript was detected. I couldn't attach the report; it's an outside report. And we did a cytogenetic analysis, which
Would you, if I say that I would like to have both a qualitative and a quantitative PCR at baseline, why would I say so? And what are the requirements for doing a qualitative PCR at baseline? Or what are the merits of doing a qualitative PCR at baseline?
Is it qualitative or quantitative, sir?
I'm sorry, quantitative. Sorry, I'm sorry. So forgive me. Quantitative PCR. Why would you want to do a quantitative PCR at baseline?
because we get if done at the baseline, we know the baseline value, and based on that, in the further reassessments, we can know how much it has come down. Attainment of milestones.
So if you do a quantitative PCR at the baseline, what is more important? Is it the percentage or the PCR ABL copies?
Per copies of percentage.
Okay, so what's how do you utilize that the data that you have at baseline for the quantitative PCR?
So it is based on international scale. The quantification is based on international scale. The attainment of log reductions based on the log reductions in the transcript. At specific time points, we are defining whether it is responding or whether there is a warning sign or a failure sign.
Okay, so you're looking at the log reduction, that's all right. But what about any other aspect? Sometimes like the velocity of decline of the quantitative PCR, which has also got a significant effect. And what was the, which, what, and if that is the case, what do you know about it? Though many people don't use it, but it is about is that a more sensitive indicator, or is it the value of less than 10% at 3 months, which is a good indicator, all right, which is more widely used, but is the velocity of decline a more realistic value? Are you aware of that we do what we look at as a velocity of decline, or the slope of decline, as we call it? Do you know about the slope of decline of the quantitative PCR?
Sir, I haven't read it.
Yeah. So Sovereignty and the thing, and also Tim Hughes and his group from Royal Adelaide. I mean from Royal Adelaide. So if you have so basically sometimes you can have 400%. Sometimes they report 400% at baseline. Sometimes you say that at 30%. Sometimes you say 40%. So if you have a decline, say from 40% to 10%, as against a decline from 100% to 10%, which is the one that you're more happy about?
100 to 10.
Why?
Velocity of decline.
The velocity. So the slope of decline is more acute over here, suggesting that the sensitivity to the tyrosine kinase inhibitor is more superior. So it's a superior parameter actually to identify the slope of decline as against the as against the log decline of less than 10%, because you are the only. So what are the problems of doing this kind of a test? Have you ever thought of, and I'm sure, so the problems of doing this kind of a test is that you need to do it at very frequent intervals to show what the slope of decline is. So as against what we do at the end of 3 months, you do a quantitative PCR at the end of 3 months to see what the decline is. Here you have to do it every month actually to see what the slope of decline is. And if that slope is not acute enough, then we are not happy with that response. And that has actually translated into long-term differentials in the outcomes of such patients to a defined treatment. So that's just a thought. Let's just go ahead. So if it is feasible, it'll be a more sensitive assay, but we all use as you rightly said, we use the logarithmic decline at the end of 3 months. At the end of 3 months, that's right. Yeah. Okay. Go ahead, please. Yeah.
So what are the two factors which are associated with better survival? That's overall survival in CML. So most of the factors were not associated with better overall survival. So most of the time, there are only two factors which are associated with better OS in CML. What are those two factors?
Sir, attainment of cytogenetic response, complete cytogenetic response.
At what time point? Attainment of complete cytogenetic response at what time point?
6 months.
It's 1 year. 1 year is associated with better overall survival than with people who do not. And what is the other factor which is associated with better overall survival? I think which we were discussing, like the logarithmic. What do you define as early molecular response?
What's this like this?
What is EMR?
The complete early molecular response is BCR-ABL less than or equal to 10% at 3 months.
Yeah. So those are the two factors which are associated with better overall survival. Okay, proceed, please.
So, in looking at you looking at this, what are the things that you will like to document at this point of time for a newly diagnosed patient of, and how will it determine the way that you need to approach this patient as far as his treatment is concerned? And how would it be the choice of your treatment? On what basis would you explore the choice of the treatment? And again, I'm asking too many questions. And what are the data to support that choice?
Going with the treatment options based on
Would you like to? Are we are just I'll just go out. I've just got a call from the hospital. I'll just take this call. Ravi Chandran, just go ahead.
Yeah. I'll take it. So,
Sir, I would like to do a risk scoring for this patient. In our
what are the various risk scoring systems you know of?
various risk scoring systems are the SOCAL score, HASFORD score, and the UTOS ELTS score. In our institute, we are using the SOCAL score.
Okay.
It is based on age, spleen size, blast percentage, and platelet count. And for this patient, it has come as intermediate risk.
Okay. What is the ELTS scoring system?
Yes, sir.
What exactly it looks at?
It is a long-term survival. That is a better predictor of survival. It predicts probability of complete cytogenetic response at 18 months. And it is a better predictor of survival of patient. It is the one which is preferred in the TKA era.
Okay.
So okay. So how relevant is the SOCAL scoring, and how relevant is the UTOS scoring over here, and also in these two, this is what we are using these days. Would you be interested in documenting these things, and are they relevant?
The scoring is relevant because in a high-risk patient, you might need to consider a second-line TKI. But for this patient, the treatment decision will depend upon what my goal of treatment is. For this patient, he's 52-year-old. My goal of treatment will be normalization of the survival. And
okay, is it actually translated into that, or is it just translated into the fact that irrespective of what the SOCAL score is, if you were to use a second generation tech, it just improves the depth of responses? And has that actually, whether it is a high risk or a low risk, has it translated into overall survival benefit?
for the first generation as well as second generation TKI have equivalent survival only, but the only difference is that the second generation induces faster and deeper response. So in young patient in whom we are looking at treatment-free remission as a goal, we may need to look at second generation TKI. Similarly, the chances of blastic transformation is less with second generation TKI. So that has to be discussed with the patient.
Okay. Okay. Yeah. So in a way it is, but the only issue with all this discussion about the second generation TKIs in first line setting has always been based on surrogate markers rather than that is a true defined definitive markers for us to predict. But having said that, the surrogate markers have been quite robust in predicting long-term outcomes, which has been shown in the all the studies that have been, whether it is using imatinib or whether it has been using dasatinib, or even for that matter using nilotinib. Yeah. So, but I would say that in the current, is there any argument against that for using imatinib in a higher dose for patients with high risk? Or a high SOCAL score? Is there any data to support that? Have you Have you read any landmark article which supported the use or demonstrated the equivalence of using high-dose imatinib at 600 milligrams in patients with high risk as against using a second-generation TKI? Are you aware of the CML4 study?
It's a German CML4 study.
Yes. So what do the CML4 studies say? It answered the same question, isn't it? Yes or no?
Yes, sir.
Yeah. So I would, one of the biggest arguments for using the second generation TKIs in this thing, I would encourage you to actually go and read the CML4 study in detail, because it's one of the most balanced way of arguing for a higher dose imatinib. The other aspects are different, okay, the tolerance levels and this, but it said it was a dose adapted therapy that was looked at over there, and actually it negated the sometimes the actual benefits of a, a second generation TKIs over there. So I think we have a little bit more time, so we should go ahead, Jayachandran, so you can.
Yes.
Yeah. Yeah. So let's go ahead. Yeah. So I would encourage you to, all of you, to actually read the CML4 study. It's a very important, if you ask one of the single most important studies that one needs to read, it is the CML4 study. Yeah. Yeah, please. Yeah. Go ahead. Go ahead.
So for this patient, considering the age and my goal of treatment as well as the cost effectiveness, my choice of treatment would be imatinib. But I will discuss the option of second line TK also with the generation TK also.
Well, I didn't get it. What was the so-called score? This patient so-called score?
Intermediates.
Intermediate. Okay. Okay. So would you be inclined to use a higher dose over here because it's an intermediate?
No, sir.
Okay. All right. Then how do you monitor these patients? Yeah.
For monitoring, initially for assessing the hematologic response, I will be calling with, he is now having a very high count. So I will be calling back him weekly, at least for 4 weeks.
So is there a role for starting this patient on hydroxyurea to get the counts under control, and then add the TKI, or simultaneously use the TKI and then withdraw the hydroxyurea? If given a choice, what would be your sequence?
First, we will start on when the patient presents with this high count, without waiting for the BCR-ABL confirmation, we will be starting on hydroxyurea, and then once the BCR-ABL is confirmed, we will start.
Okay. So that would be a reasonable option, because sometimes when we use it in combination, you can get some very profound neutropenia in these patients. Yeah. So any thoughts on why some patients develop very profound neutropenia on the initial phases of treatment for CML? Okay, we'll discuss that later. Let's get ahead with, yeah. Let's go ahead. So this patient, you would monitor the patient for the hematological response, and would you be interested in doing also identifying the Utah score over here for this patient? And what does the Utah score signify for the patient?
It's a better predictor of survival. So Utah CLTS score is a better predictor of survival.
And what does it predict actually?
CML specific survival at 10 years.
Yeah, but it also predicts some very important thing.
Some response at some time. What is it?
Complete cytogenetic response.
Yeah. At what time period?
At 18 months.
At 18 months. That's right. Because what we must understand is, many a time we look at cytogenetic responses, and this is for the other students who are listening. We look at cytogenetic responses and we are anxious to see at 6 months. But actually the cytogenetic response, what we have at 18 months, is the most important value that we have to, or even at for 1 year, but at least you should have a complete cytogenetic response at the end of 18 months. So that's what it predicts, the UTOS score. So it's always useful to write down the UTOS score also for the patient, though nowadays we don't do too much of cytogenetic response assessment at the end of 6 months in patients because it entails doing a bone marrow. Yeah. So, okay. So then how did this patient do? I mean, we have the data of this patient. Yeah.
Sir.
Yeah.
Sir, diagnosis.
Okay, this is a newly diagnosed patient. So you put him on imatinib and say at the end of uh, at the end of 3 months, he has a BCR-ABL transcript value of about 15%. Does that mean that you want to change your treatment strategy over here?
So at 3 months, the transcript ratio should ideally be less than 10%.
That's
So
right.
at of 50% is a warning sign.
Yeah. But does that trigger you to change the line of treatment?
No, sir. We can continue.
So there is no recommendation for changing of treatment at the end of 3 months just because it is only just a predictive factor. All right. So when would you want to think about changing the treatment? At what are the time points and what are the milestones, if not achieved, will want you to change the treatment?
Yes, sir. At 6 months, the RT-PCR BCR-ABL transcript should be less than 1%. 1 to 10% will be a warning sign, and more than 10% is a failure sign. Just failure signal, and if it's a failure signal, we have to change. Okay. At 12 months, if the BCR-ABL is more than 1%, we have to consider it as a failure.
Would that trigger you to do a mutation testing over here at this point?
Yes, sir.
Yeah.
Mutation testing as well as extra cytogenetic study.
So when we're talking about mutation testing, what are the situations where you would ask for a mutation testing at baseline? At baseline. Is there any indication for doing mutation analysis at baseline? If not, then what are the indications that you would ask for a mutation analysis at baseline?
Sir, I don't know.
So any patient who is in accelerated phase of blast crisis will warrant a mutation analysis and in these patients. Otherwise, you don't ask for mutation testing at baseline. And of course, any patient who's Ph positive ALL, who's diagnosed, who may present like a lymphoid blast crisis, or maybe a lymphoid blast crisis, which we assume is an ALL, Ph positive. All those patients also should have ideally a baseline mutational testing done to identify any potential, because they have a high possibility of having a higher mutational burden in these patients, and that will help us decide on the kind of drugs that we need to use. Yeah. So this patient, you have started imatinib, and so you have said that, okay, we'll continue. And at 6 months, and so if the patient has achieved a 10% less than 10, a 10 or 10 less than 10%, how would you counsel this patient?
Has not achieved.
No, has achieved 10%, less than 10%. How would you counsel this patient? What would you counsel this patient in?
If we have achieved the required milestone, the treatment has to be continued, and the likelihood that.
So how would you counsel him as to how he has to be monitored, and what would you insist on in terms of monitoring, and what would you be counseling him for long-term outcomes for these patients?
So I counsel him regarding the reassessment, which will be due on 6th month, 12th month, 18th month, 24 months, and thereafter every 6 months.
Yes. No. What I understand. What is the most important point you insist at 3 months?
Yes.
Basically, patients should be uh, very, in the sense, they will take the tablets very regularly till the symptoms are they have become symptomless. So, what is the most important thing which you would counsel at the time of 3 months when the patient has achieved a better response less than 10%?
Compliance and follow-up. Strict follow-up.
Compliance.
Compliance. And
So,
there are
what is the data on compliance for CML? Can you quote some studies which demonstrated about the importance of compliance for CML, based on which we always insist that compliance is an important part. And if you don't comply within a certain framework, your chances of losing your response is so much. Are you aware of some of the studies? Which actually, you need to know these things. Yeah, you need to, these are all very important studies that have come up to demonstrate each aspect of management of CML. The ADIGU study, which looked at the compliance factor. And do you know what that compliance study demonstrated? So even missing a tablet twice a month had its impact in terms of the responses that you achieved. So it is that sensitive. So you need to counsel the patient about compliance at this point of time. You need to counsel the patient about monitoring of the drugs. You need to counsel the patients about what are the milestones that you expect these patients to achieve at different time points. And then you also need to counsel the patients of the potential for treatment-free remissions, provided you are able to satisfy certain criteria, which also sometimes incentivizes them to actually take the treatment properly. Yeah? Dr. Ravichandran, do you agree with that? Yeah?
So,
Yeah. So these are sometimes it is because of inadequate counseling, especially in CML patients. And many a time you will find that patients tend to be non-compliant, and that's one of the reasons for not so optimal outcomes in CML patients. Yeah. All right. Dr. Richard, any other questions? That we've just been very practical. We've been looking at very practical aspects of things. Yeah. Now, suppose the patient loses the hematological response at, say, at 18 months, or is demonstrating a loss of the molecular response over a period of time which you're monitoring. How would you approach this patient at that point of time?
We should do a repeat bone marrow. Should be considered as a TKA failure, loss of response. So repeat bone marrow is required.
what do you ask first before going up, jumping into?
Compliance, whether he has been compliant and adherent to the treatment.
Okay. Yeah.
Ask
So
for
if
compliance.
if he is compliant, then that's one thing that if he is compliant, then the next step is, of course, doing a bone marrow. But would you first look at the BCR-ABL transcripts first? And if the transcripts are rising, the clonal evolution of is indicative of what aspect of CML?
Transformation.
Transformation to? Yes, a blastic transformation. So it helps in determining the need for doing a allotransplant for such patients earlier than later. If you do encounter those kind of clonal translocation, then our inclination to advise an allotransplant for such patients would be much more, because as such, they are having an unstable marrow. And even if you were to use some of the third generation medications over here, and of course, we need to do the mutational testing over here. especially we are interested in finding out a pan-resistant kind of a mutation, the T315I mutation over here, and also the different mutations to help us choose a medication for this patient. Yeah. So, yeah, please go ahead. Yeah, sorry.
One last question, like, what would you what would you qualify as an ideal patient for TFR? Tell me what are the various qualities, like what are you think, what are the, what all would you look at for the patient's ideal patient for a treatment-free remission?
So the patient should have been on TKI for about 5 years, and he should be maintaining a deep molecular response for at least 2 years. It is also better that the patient is having a quantifiable transcript, and he was in the blast CML chronic phase in the diagnosis.
Few more things.
He had a response to first line TK. He didn't fail on first line TK, and
so there must be no warnings. He must have all the timelines should have been fulfilled properly. No compliance issues should be there. All these things, and it is always like it's not better to have a quantifiable transcript. It should be a quantifiable transcript. Always, we cannot take a patient who is non-quantifiable into a TFR patients. Okay, good. It will be possible.
Yeah. Yeah. So I think nowadays the management of CML is so very well defined that we just need to follow the framework of management of such patients. It is not so much to do with the kind of drugs that we have, but it is about how discerningly we choose the drugs for the treatment of those patients, and how we counsel the patients and importance of compliance. And also we need to keep something in our choice of future management for such patients. So what are the new drugs on the block for treatment of CML that you know, and how are they different?
So recently approved were asciminib, have omacetaxin. Omacetaxin is a translational inhibitor which is approved in patients who are intolerant or resistant to two or more lines of TKI.
So we used to have a drug called homoharringtonin, which is actually from the China, which was what we used to use. And that is actually omacetaxin, which was popularized by the MD Anderson group. And it has some activity in 315, but nothing which is durable. So not too impressed to do. But yes, asciminib is one of the, and of course, how is asciminib different from the other TKIs?
It's an allosteric inhibitor
Okay.
that binds to the milestone site of the BCR-ABL protein. The other one, the binding site is ATP binding site.
Okay.
So they lock the BCR-ABL1 into an inactive conformation through a mechanism which is distinct from the other TKIs.
That's right. So when we are looking at it's active in the 315I mutation also. So if you had a choice of using asciminib vis-a-vis ponatinib for a patient with 315I mutation, what would be your choice?
So whether the patient is be fit for a transplant, taking up for transplant or not, that will guide my decision. If transplant eligible, then we consider ponatinib, and then once the molecular response is attained.
Why would it be otherwise? What is the transplant eligibility got to do with your choice of using asciminib or ponatinib?
Patient.
In fact, it's never been compared together, but it's the activity of ponatinib actually at 15 to 30 milligrams per day as good as or equivalent to what we have with asciminib on equivalent dosing. But you must understand that asciminib is used at 4 times the doses in patients with T315I mutation as against the conventional doses. And it's an incredibly expensive medicine to use it in those, as such, in conventional doses also as of now, and in higher doses for T315I mutation. But in terms of the equivalence, ponatinib is probably for a T315I mutation, probably ponatinib is probably equivalent, and it's a drug of choice that has always been in T315I mutation. And you're right, you can lose responses, and one may have to look at doing an allotransplants if feasible in these patients. Yeah. Thoughts, Dr. Jayachandran? Yeah, and I think we are already, is that Bobbin? Are we in time? Yeah.
8:30, sir, we can stop.
Yeah.
Jayachandran,
Yeah.
any closing
Thank you.
comments?
Are there
Any
Nothing.
advice to the students?
Nothing. Just
Okay. Okay.
well listed and concluded by.
Thank you, Hari sir, and thank you, Jayachandran, for that extensive and very elaborate discussion on CML. So splenomegaly can be a short case, but then it can take us anywhere in our exam. So we all know that it can take anywhere if it comes as a short case. It can even become a long case. So almost all the aspects were discussed today. Thank you. So I think it's time for us to close. So one more announcement we made. I think we had discussed Ampok is having its year-end conference in December. That's on 14th and 15th. So the last date for postgraduates to send the abstract is on 30th of October. So I request all the postgraduates to send the abstract. And as it has been discussed, we are shared in the group. We are happy to provide travel grant to students who are coming from outside state, and sharing accommodation will also be provided to all the postgraduates. But then we need to be informed well in advance. And one more thing, even though Ampok is hosting this meeting, we are happy to include postgraduates from other parts of the country, not outside Kerala, also to present their cases. So if anyone of you are interested to present the case, preferably we encourage the third-year residents to present. You can either send the request to Dr. Sujit or Dr. Arun, or you can post it in the group so that we can make the arrangements. So thank you. Thank you, everybody.
Thank you, sir.
Good night.